Hello, everyone, and welcome to today's Balancing Act discussion on obesity care, digital health, and innovative treatments. My name is Dr. David Cox. I'm a health journalist, and I'm going to be your host over the next hour for this insightful session brought to you by Yazen Health. So our focus today is obesity, a complex and multifaceted disease that affects millions of people worldwide. But despite its prevalence, there are still many misconceptions surrounding obesity. Today, we're going to delve into the latest research findings from Yazen Health and explore various topics such as the biological and genetic factors influencing obesity, the role of digital care delivery in managing weight, and how we can overcome the stigma associated with this chronic disease. So to discuss all of this today, we have an incredible panel of experts with us who bring a wealth of knowledge and experience to the table. So I'm going to introduce them one by one. We have Yazen Halford, who is head of the School of Psychology at the University of Leeds and former chair of the European Association of Obesity. We also have Dr. Nick Feiner, who is former senior principal clinical scientist at Novo Nordisk and honorary clinical professor at University College London. We also have Dr. Martin Carlsson, who is co-founder and chief medical officer at Yazen Health, who specialises in endocrinology and metabolic disorders. And finally, we also have Dr. Punam Krishan, who's an NHS GP and co-founder of the Medic Mum podcast, which has a focus on maternal and family health. So let's get started. So initially, we're going to give some context to our conversation. So science has proven that obesity is not just a matter of lifestyle choice. It is a chronic medical condition, which is influenced by a variety of factors, including genetics, biology, and environment. Yet despite this, misconceptions still persist, and many people suffering from obesity still face a significant amount of stigma. And our goal today is to shed light on these issues, discuss the latest research, and explore how digital health solutions like those offered by Yazen Health can make a big difference going forwards in the future. So perhaps to get things underway, Martin, I'm going to come to you first. I've seen the latest findings from Yazen, which show that 37% of people in the UK still mistakenly view obesity as a lifestyle choice rather than a chronic medical disease. I mean, how surprised were you to see that?
No, I'm not surprised. I mean, it's a common misconceptions, and there are many myths about obesity. But I think that one of the biggest myths is still that obesity is not a disease, that it's your own fault that you're fat or overweight, and that obesity is due to your bad character and that you're lazy. And many people still think that if you just tightened up, you would be able to eat less, exercise more, and then would you lose weight very easily. But that's all wrong. We know that obesity is a chronic disease, as you said, and we now have understood that this disease is due to the brain satiety and hunger centers not being governed in a normal way in patients living with obesity. And this hormonal imbalance in the brain and in the body, it can be due to genetic factors, but it's also a lot due to our modern environment. And researchers and doctors often call this environment an obesogene environment. An example of this is that you can nowadays find easy to chew, good, high-calorie food everywhere, and we are not built for this environment. It's easy to become overweight in such an environment. It's not your fault. But for our patient and for society, it's important to emphasize that obesity is not due to bad character. And our patients need to hear this. They have heard it so many times that they have bad character and lazy, that they often themselves believe it, that is true. And I think it's also important to know that people who experience weight stigma may avoid seeking physical medical help or weight loss support because, unfortunately, they fear judgment and criticism from healthcare providers and others. And this avoidance can prevent them from getting the help they need to manage their weight and any other related health issues due to the obesity. And for these patients, in my experience, digital care is actually very well suited.
Yeah, Yeah, I mean, those are good points. I mean, Punam, I'm going to bring you in because I mean, I guess as a GP, you're seeing lots of people suffering, with obesity, like so on a daily basis. What are like so kind of some of the consequences of the stigma which Martin mentioned? Do you feel it does kind of prevent people from seeking out appropriate treatment?
Yeah, no, absolutely. Would echo the things that Martin was saying there. I think that it's for too long the damage has been done because as a collective society, media has had a role in really honing in on this concept that actually it's your fault, that you're lazy, that you haven't been motivated to make any change, that it's your poor diet, lack of physical activity. And what that does over a long period of time is it really enhances that sense of stigma. That weight bias hasn't always just come from the public or the media, but actually, unfortunately, even in medical history, there's been a lot of weight bias from medical professionals at times who have perhaps labeled people and patients who are living with obesity as it being their fault. But we know better now, as we just said there. And the consequences, what I see is people have either they will delay coming in to seek help. They will come in and feel very embarrassed or feel a sense of shame and will have put it off for a long period of time, which will have negative impact on their physical health. But repeated weight stigma also has a huge consequence on your mental health and your emotional well-being as well. It affects the way that you interact with your loved ones. It affects the way that you show up in the world. It affects your self-esteem, your confidence, and over time can actually increase things like anxiety, depression. And we see that across all age groups. I'm a family doctor. I see this in children increasingly as well, with their accessibility to things like social media, but I see it in older adults too.
I mean, what do you think we can do to kind of tackle this stigma?
I think there's so many different things that we can do. I think as a starting point, having these conversations, having healthcare professionals say these things out loud is essential. I think approaching anyone who is living with weight issues with huge amounts of compassion and empathy is a massive starting point as well. I think collectively there is just far too much. We live in a cost of living crisis. People find that actually access to healthy foods is a barrier. We find that being able to open up and talk about their issues is a barrier. So I think education, awareness, accessibility to healthier food choices, to healthier environments where people can actually go and do physical activity. I think that these are all things that would make a huge difference.
Yeah, I mean, that obesogenic environment is a huge contributor. I mean, Jason, I'd like to bring you in here as well, because, we've had many of these genome-wide association studies over the past 10 years looking at obesity. Perhaps you can tell us a little bit about what these studies have told us about the genetic basis of obesity and how this, combined with that obesogenic environment, makes people more likely to develop this disease.
I mean, what is interesting about the genetics of obesity is how many genes are linked to it. And secondly, many of them, or the majority of them, are linked to the brain. And it really speaks to the appetite systems, the homeostatic appetite system, but also the hedonically driven appetite control, and how that is fundamentally undermined by this biology, by these genetics. So people living with obesity, their hunger is not sufficiently suppressed by their food intake, it quickly rebounds, but also they are more naturally orientated to food cues within the environment. And that's hardwired in. So they have poor biology of regulation and they're orientating to food cues within the environment. Now, if you've got an environment which is actively promoting excess consumption in terms of regulatory requirements of food, then it's a perfect storm, because people living with obesity have problems resisting, and the food is not filling them, and you put them into an environment which is actively encouraging them to consume.
Yeah, that's very true. I mean, Nick, perhaps do you have kind of any thoughts on this? I mean, have there been any kind of interesting new studies in the last kind of 2 or 3 years kind of on obesity and how kind of those brain chemistry changes help to kind of perpetuate the disease?
Sure. So, I mean, following on from Jason, we have increasingly unraveled the physiological pathways that control energy balance. And it seems that the vast majority of those are, if you like, designed to ensure that we maintain our weight, and however high our weight is, that we maintain that weight, and when we lose weight, that we attempt to get back to that weight that we were. And it makes sense, if you like, from an evolutionary perspective, that it would be that way. Now, of course, there is, on top of that, a degree of what's called executive control. You can decide at this moment whether to lift your coffee mug up or not. But it's a bit like telling somebody who's drowning, well, all you have to do is not breathe. You know, you can hold your breath, surely. And, you know, it's, to take the drowning analogy, it's the person is in the wrong environment. Now, what we do know as well, which I think is very important, maybe 5 to 10% of children who develop severe obesity below the age of 4 or 5, we know that 5 or 10% of those children will have a major mutation in one of the genes involved in these physiological pathways. In adults, those mutations are obviously less common, but we know that an increasing number of bad variants of genes will lead to increasing obesity. In particular, one gene called the FTO gene, 1 in 16 people carry the variant which leads, when you do the experiments and the studies, to them not getting the same degree of satiety or fullness after a meal compared to somebody who has the healthy FTO variants. So genetics is very strong. That is, in my view, a large part of the cause. The mechanism, obviously, still relates to those factors relating to energy balance.
Interesting. Yeah, I find these studies on the genetics kind of so interesting because, you know, in the media, I suppose like even kind of 5 years ago, like so relatively recently, we've sort of perceived kind of obesity as almost being this kind of single condition. But, you know, we're now kind of increasingly realizing there's all these many different subtypes of obesity just with other chronic diseases. So, I mean, I guess that kind of implies it's probably not going to be like a one-size-fits-all treatment. And, you know, Nick, Jason, I mean, do you feel like sort of health tech platforms have a role going forwards in perhaps helping develop more personalized care plans for different people with different subtypes of obesity?
Well, perhaps I can jump in. Absolutely. I mean, we already have a situation where they're rare, but certain known gene abnormalities which can be treated specifically by a specific drug. So we're beginning from that point of view to get into personalized medicine. But I think, you know, where I think the real challenge comes, and I suspect Jason may say something about this, is, of course, personalizing medicine, perhaps more related to the well-defined behaviors and drivers of food consumption in individuals, the sort of psychobiology, if you like.
Yeah, Nick, I think that's a really important point you make. And when you are working with people living with obesity, their life history and their weight history are very unique. And it's understanding those events and how those have impacted upon that individual, which helps you understand how they got to where they are today. And that will include a history of lots of weight management attempts, which have been, for a variety of reasons, not necessarily successful. So personalized medicine is very important because you're treating the person, and each individual is different. Now, there are different biological variations, and there'll be different responses to, say, drugs or surgery or medical interventions. But I think what's really important is that personalization around the individual that you have in front of you and the issues they face and the challenges they face within their food environment and with their broader psychological environment at that moment.
Do you think this is perhaps, you know, what's going to be the way forward in the next kind of few years? Because obviously we've had the explosion in like some weight loss drugs of semaglutide, we've had like some tirzepatide, and now we've got these new like drugs in trials as well, like retatrutide. We're getting more and more treatment options. Do you feel, you know, perhaps Martin, you could give your perspective on this. Do you feel that kind of digital health platforms, that's going to be one of their key roles to help clinicians choose the right drug for a particular patient?
I mean, I just want to say something about the genes first, because of course there are very few major genes, and then you can say that a child could have severe obesity. But the main the most patients, adult patients with obesity, they have many different gene subtypes that together with the environment creates the obesity. And I think that it will be difficult to do genotyping in most obese patients in the future, because there are hundreds of genes that will lead to obesity. But of course, it's important to know if you have a close family member who are obese, you are a very big risk yourself to have obesity. But your question was about the advantages of digital care in this context, David.
Yes, exactly. Yeah, because I know you have your blood tests kind of which goes with your platform. Do you think that can perhaps help kind of tailor and point clinicians towards the right drug for a particular patient in future?
Yes, I think, we are agreed on that obesity is a chronic, relapsing, progressive and complex disease with many genes, and the same treatment does not suit everyone. One size does not fit all. And there we know that patients, they respond differently to the same treatment, and therefore we need to personalize the treatment. So, for example, we know that with one particular medicine, some patients can lose weight very effectively, but others not. The same with diet and exercise regimens. And this might be due to genetic factors and difference in metabolism or others. For most patients with obesity, modern drugs like GLP-1 or GIP, like semaglutide and tirzepatide, Mounjaro, or Ozempic, they work very well. But for others, it may be necessary to change the treatment and add other medicines. And it could also be due to personal preferences and cultural backgrounds and lifestyle choices. And this also affects how feasible and sustainable a particular treatment will be for someone. And we must also consider other health issues like diabetes, heart disease, hypertension, or joint problems. So we need to do treatment plans that consider all these conditions to ensure safe and effective care. So and if you have a digital platform, you can continuously change the medication and the treatment that is very beneficial for these different variants of obesity. We call obesities now. It's not one disease, it's many diseases.
That's a good point. Yeah, and I find it interesting what you mentioned about the non-responders, because I remember finding that so interesting when looking at that groundbreaking 2021 trial of semaglutide. While it attracted so much kind of attention and sort of hype at the time, I think there was still 14% of people in the trial who didn't actually respond at all.
It's also actually with bariatric surgery. There are non-responders, even though so with all treatments there are a subgroup that are non-responders actually.
Yeah, I think that's one of the things which kind of almost has sort of slipped beneath the radar a little bit. Nick, Jason, do you think so that's something we need to kind of understand more in the kind of the next few years, in terms of treatment pathways, why people are not responsive to a particular drug?
Yeah, first of all, I just sort of emphasize what Martin said. Of course, personalizing treatment needs to be personalized not just in terms of outcomes of weight loss. The coexisting complications of obesity are diabetes, fatty liver disease, sleep apnea, must be assessed and must be, in my view, a major focus for treatment. Those are actually probably more important outcomes than the percentage weight loss or the kilos lost. So personalizing in terms of those health needs rather than a general weight outcome is important. In terms of predicting who will respond to what, that is challenging because there have been very, very few, hardly any trials comparing two different drugs head to head to look at what the different responses are, and we need those. There is at the moment a very major European grant the Sophia program, which is attempting to look at a whole variety of potential predictors of weight loss. And I think, that may give us pointers. At the moment, however, I think realistically, our best predictor is the response actually in terms of weight loss in the first few weeks of treatment. That's probably true for hypertension. It's probably true for other chronic diseases as well.
I mean, I would support everything that Nick has just said there. I think in terms of who responds to treatment and who doesn't, and whether they would benefit from a different treatment option, we're just not there yet. But I think we'll start to have that evidence. And to follow on from what Martin said, and what you've also said, David, the variance in response to these drugs, even though they're quite powerful, is quite marked across. Some people do much better than 15 or 20%, but lots of people, they're not getting any benefit at all. And that does show that, you really do need to take a personalized approach to medicine. And that can be biological markers, it can be genetic, but it could also be understanding people's behavior and the issues and challenges that they face, which will be unique to them.
And that's actually where digital platforms, I think, can be very powerful, because they allow the sort of degree of follow-up and healthcare professional patient engagement, which will focus very, very early on if there are barriers or particular enablers, if you like, of the response to treatment, much more easily than a 4-weekly visit to see the doctor or the nurse or the healthcare professional having to travel on a train to go somewhere and come back. So digital platforms can allow much earlier identification of barriers or enablers.
Yeah, I mean, Punam, what are your kind of thoughts on this from like a primary care perspective?
Yeah, I find it very interesting. I do definitely feel that digital platforms have a role. Of course, I am a family doctor. I work within the national healthcare system here, and I do believe that at every stage there should be a clinician who should be the one undertaking that history, that initial examination. And we come back to what we started off with discussing with just how complex obesity is. During the pandemic, as an example, we saw people that never had issues with their weight before finding themselves developing obesity or gaining a lot of weight over a quick period of time. And fundamental underlying markers of that was things like mental health, stress, and anxiety. I think when I am speaking to my patients, my focus is always to get to the root cause. What is it that's actually causing their weight issues in the first place? And sometimes you can find it's an underactive thyroid, actually providing treatment for that, or polycystic ovarian syndrome is another common one that I see. If you can actually help support them, get them onto the right treatment for that, often the mechanisms that they have already been putting in place for their weight management, it's just a jigsaw coming together, and they find that the weight starts to come off. So not necessarily does everybody living with obesity need to turn to a drug that's going to help them reverse that. So I think that, yes, digital can be very, very helpful. I think that there's a huge role, obviously, for those face-to-face primary care involvement with follow-up. I love to see my patients on their journey. It's why I became a doctor in the first place. And I think helping them along that, being able to also know what is involved in their lifestyles, you get to really meet people's families, you get to know their environment, you're in their community, and you can really firsthand appreciate the barriers that they're facing.
Yeah, I was wondering, have you, do you think it's a problem that's the amount of hype which kind of like some weight loss drugs have had like in the last kind of 3 years? Do you get patients kind of coming to you, even if the actual underlying cause of their obesity is something else, they still really want to take those drugs, even if they, and also, even if they do take those drugs, they don't respond, so people kind of getting very disheartened by that.
Yeah, of course. There has been a huge hype over the years. I think lots of celebrities have endorsed them. And, we can't underestimate how incredible some of these drugs that are on the market are for people that have really tried absolutely everything. However, what I have seen is that there has been an increase in people who not necessarily meet the criteria for these drugs, and have therefore been sourcing them from online places where they have not perhaps receiving the regulated drug, or they have ended up taking these medications without anybody monitoring them, without monitoring their blood results, and have come in with complications. And that is a huge worry for me as a GP. I think that anybody that wishes to try out medication, it's important that they have the right information to make that informed decision in the first place, and that we've explored all avenues and assessed that actually they are eligible for these medications. And it's not just, I think that the hype over the years has been that it's a quick fix. That's what people want. Everybody wants a quick fix for not just obesity, but for all medical problems. And there is no quick fix. It's a partnership. It's coming back to that individualized care, but it's also about the medication in tandem with lifestyle behavioral changes that will make the long-term shift. And I don't think that this information is relayed to the general public when all we see is, look at what this drug did. Here's my before and after picture.
Yeah, no, definitely. I mean, I think that's going to be particularly key kind of going forwards as we get kind of more and more studies kind of coming out on like semaglutide. And I remember like sort of last month, after kind of some of the results on like the European Congress on Obesity, some people kind of saying like so semaglutide should be prescribed like sort of kind of, you know, blanket wide, or almost like statins. You know, Jason, kind of what are your sort of like thoughts on that? Obviously, like these drugs have enormous potential to help some of the comorbidities which can like sort of accompany like sort of obesity, but do we need a little bit more of a tailored approach in terms of deciding who is relevant for them?
I think one of the things which concerns me when we talk about people taking these powerful medications and them not working for them, that just kind of reinforces feelings of failure in those people living with obesity. And we know about the mental health issues associated with obesity. And I think one of those problems is all the hype around these drugs. Brilliant, there's this brand new drug, it's there in the market, and you take it or you get it prescribed and it doesn't work. How do you interpret that? And I think without having that support and help, which Punam has talked about, I think it's really, really difficult. And I do worry about the impact of that.
Yeah.
And of course, it's more than weight loss, isn't it? I mean, you know, the idea that weight loss will solve all of the problems that a patient who's lived with obesity for many years has is, of course, you know, it's not necessarily going to solve marital problems. It's not necessarily going to mean they get a bigger salary. It's not necessarily going to improve their housing. So, you know, there are many factors behind, if you like, this patient that may need addressing, which is why I think, you know, all serious medical treatment of obesity should be multidisciplinary, multifactorial, to allow these different components to be addressed. Not necessarily everyone in every person, but the ability to go into those areas needs to be there. Physical activity for support for people who've been very inactive, mental health issues, and so on. So, you know, that's really where we need to be going in terms of our treatment. And again, I think this is where, I mean, I entirely agree that the role of the primary care doctor is paramount. But of course, being able to access these different skills and different disciplines, however we can try and do that to make it easier, and digital platforms can do that, is to be welcomed.
Yeah. Definitely. I mean, I think we're now just going to like to switch to like a Q&A, and I'd encourage everyone watching to, you know, put your questions to our panelists, because we're going to be lots of kind of answering lots of questions from you over the next 20 minutes, and we're already starting to get some coming through. Perhaps just to begin with, lots of something from Ellie Heath, who mentioned lots of a fascinating presentation at EASO earlier this year. Like, you know, Martin, lots of Nick, you know, what do you think about this? Can lots of behavioral phenotyping and tailoring lots of psychological and pharmaceutical interventions, is that the way forwards, do you feel like?
Yes, absolutely, I would say. And I mean, one beneficial aspect of digital care is that you can respond so quickly, and you can also add medicines. I mean, people, they eat from different reasons, so emotional reasons, some, and then you might need other treatment plans, and therefore but if you have a digital platform, you can send questions and you can have access to educational programs all the time, and then you can also change the treatment very quickly. I mean, it's not wrong to try sometimes a medication and then or something, and then you can go back again if it doesn't work. So I mean, you must have a holistic approach to the patients, and you also need to use what Jack said, Nick said before. I mean, it's important that when you lose weight, that you eat correct and you eat a lot of proteins, that you don't lose too much muscles, and you need to have, if you eat less calories, you must eat enough minerals and vitamins. I mean, it's a treatment that might be for many years. If you eat half of the calories for 1 year, you must have enough vitamins and minerals. So, I mean, the holistic aspects of this, and that you can also change the treatment. That's very important, I think.
Yeah, that's something we haven't actually really touched on so far. You know, the importance of good nutritional advice alongside like these therapies. I mean, you know, Nick, Punam, do you have thoughts on that? The importance of that?
Yes, but could I just come back to the study that was mentioned, because I think I think it's a very interesting and a approach that may hold promise. I mean, I have a lot of criticisms about that particular study. It wasn't a randomized controlled trial. What they did was they essentially defined 4 different types of behavior, and they then chose what they thought would be the best drug, anti-obesity medication for each behavior, and then looked at the outcomes. But there was a lot of crossover between these 4 behavioral phenotypes. They didn't randomize or cross over exposure to different drugs, so you don't really know whether somebody who did well with drug A would have done equally well with drug B. So the study, I think, is really it's showing the way forward, but I would not want to take the findings, particularly these 4 behavioral phenotypes, lock, stock and barrel, you know, and apply it in clinical practice yet.
I agree on that.
My view is premature, but it, you know, very, very important looking forwards. In terms of nutrition, yeah, I mean, it is very important, because we know that many people who live with obesity, many people who don't live with obesity have very poor nutrition at the moment. They have inadequate protein intake. They have rapidly absorbed carbohydrates causing peaks of blood glucose levels. Many have vitamin deficiencies. And of course, if you have less of a bad diet, it's going to be an even worse diet. So, you know, if you're going to give treatment that is going to reduce energy intake and therefore reduce the amount of food you eat, you want to make sure that the foods that person is eating are of high nutritional quality. And that is a really important challenge, I think, for all of us who are involved in weight management.
Yeah. Punam, what do
I would second that. I think that when we're counselling somebody on their weight management journey, having that input, so within the national healthcare system here, if I am referring someone to the weight management services, I'm trusting that they will then have the input from a dietitian or a nutritionist as well, because it's about reprogramming and educating yourself. I work in a very deprived part of Glasgow here in Scotland, and certainly none of my patients are aware of what forms a healthy lifestyle and a healthy diet in the first place. And these are people who are also most at risk of obesity and indeed make up the population that are coming to see me. So we're really starting back to basics, which is, okay, well, what alongside these medications that you are now on, as the weight starts to fall off, this is the kind of things that forms a healthy plate. And these are the kinds of foods that you must be eating. But alongside that, ensuring that they are not becoming nutritionally deplete and ensuring that they've got the right supplements should they require them is very important. And when people are accessing medication online, for example, without any education or support, they run the risk of then becoming malnourished or developing problems of vitamin deficiencies, and then wondering, well, why am I getting pins and needles? Why have I got, aching muscles? So it's very important that they have that all of this goes hand in hand. It is not just take a medication and that's you in 3 months' time. You'll be good to go for the rest of forever.
Yeah, no, definitely. Is that holistic approach is so important. I mean, I'm just going to go to another question we've had come through in the chat from Javier, who asks, are there problems of drug shortages in Sweden? And, if not, how has the pharmaceutical industry reacted to solve them? Martin, perhaps you'd like to give the Swedish perspective on that. How, what is the situation at the moment?
Yes, I mean, referring to GLP drugs, there are drug shortages in Sweden. That's the short answer.
I think that's a challenge everywhere, I think, at the moment, isn't it? I mean, and it kind of relates to something which has been very much in the news over the past week, which is that, there's been almost it's been too easy for people who aren't obese to get hold of lots of these very kind of potent drugs, which potentially have some risks for them in terms of side effects. But then that's prevented people who do actually have the disease from getting them. I mean, what do you think, Nick, would you like to speak about that?
Yeah. Well, I mean, in the UK, of course, many drugs are fully reimbursed, if you like, within the health service. When it's come to anti-obesity medications, there has been essentially rationing of reimbursement. And the challenge with the newer GLP-1s, they are very expensive, is that the body NICE that determines reimbursement have set very high, if you like, thresholds, much higher than are in the drug label. And on top of that, even when NICE have recommended, for example, for a body mass index above 35, or somebody with a body mass index above 30 with type 2 diabetes, the individual areas who are responsible for providing and therefore paying for healthcare are saying, we haven't got the money. And at the moment, there are big discussions in each area, I think, between the leading, if you like, specialist clinics to say, how many patients are we going to be able to treat? Which patients can we treat? So there is now a prioritizing process. For example, people who are being denied a kidney transplant because they're deemed to have a BMI that's too high would clearly and are being a high priority. So I think in the UK, the problem, I think, is not so much supply. I think it's actually the restrictions that are being put in place on a health economic basis.
Yeah. I mean, what do you think about, I think there's some kind of proposed changes to BMI, and the whole idea is to try and classify anyone who's over 40 and has a BMI of over 27 as obese. Do you think that has some implications for this?
Well, BMI of 27 to 30 used to be called, or was beginning to be called, pre-obesity, on the basis that many of these people would develop obesity when they crossed the threshold. I mean, there's always this argument about whether BMI is a useful diagnostic tool for somebody with obesity. And I think it's, very useful for population studies. At an individual level, I think we do need to do more than make a diagnosis just based on BMI alone.
Yeah. Jason, do you have any thoughts on that? Do you think we need to move beyond BMI?
Yeah, I mean, actually, the conversation about beyond BMI has been quite a long one in the field. And certainly I agree with Nick about the idea of pre-obesity and things like that. People have been discussing these as concepts. But I think in terms of clinical diagnosis, I think, yes, BMI is one part of it, but there are other health indicators. There's where the fat is distributed. There's the risk factors, and tests for those, whether there is actually an obesity-related NCD already present. So I think, I don't want to speak on behalf of Punam, but there's a lot of things which go on in a consultation above and beyond BMI.
Yes.
Yeah, Martin?
Yes, and of course, nowadays there are these intelligent scales that you can have your lean body mass and your fat mass, and that's in some cases you can use this. What we do in Yazen, we also of course measure waist circumference and neck circumference, and we estimate the fat mass in that matter also. So I mean, you can actually have a normal BMI and be very obese. That's, you know, and there are also ethnical differences in this. So I think that it's a lot of discussion about BMI.
And also, I mean, I think like so the connection between obesity and so many other diseases is also kind of really important, because we're seeing like so these clinical trials of semaglutide for, I think, even like of you know, kind of dementia like so at the moment, to see if that can like so reduce kind of risk. Do you think that like so that whole kind of family history and the connection like so to other diseases is going to also become like so very important when determining like so the right kind of weight loss regime to offer a particular patient? Yeah, Nick, Jason, do you want to?
Yeah, I mean, I think it comes back to the issue about what are we actually treating when we see somebody living with obesity, and we're treating more than just how much flesh they have on them, if you like. And clearly, if we can prevent that person having a heart attack, if we can prevent them having renal failure, if we can prevent them developing Alzheimer's or a stroke, those are really, really important outcomes, which I think transcend the actual kilos lost weight outcome. And of course, what is particularly interesting is that we're now seeing with some of these newer drugs, the GLP-1 agonists, we see it also with the SGLT2 inhibitors for diabetes, which don't produce really very much weight loss, that some of these outcomes are occurring and they're independent of the weight loss. So these drugs, if you like, are both producing weight loss, which will reduce risk factors, but independently are reducing the risks of having a heart attack or developing renal failure. And that is, of course, going to transform, I think, their use. I mean, it may well even mean these drugs are used outside of obesity, but that's a long way in the future.
Yeah.
And I mean, also, we need to think about what is the patient's motivation, what are their goals? And often patients are less concerned with their weight. People think, oh, it's all about appearance, and that's what the patient's motivation is. It's often about health. It's about living long enough to see your grandchildren. It's those sorts of concerns which are often quite important to people. And I think we need to recognise that. And I think we also need to come back to this biological point about people living with obesity feeling less in control of their appetite, or feeling the food is controlling them. And what we need to be helping in obesity management, including treatments like drugs, but also the personalisation, is helping put the person living with obesity back in control.
Yeah, that's interesting.
Or giving them control.
Martin, did you have something you'd like to
I just wanted to comment, because I come from the diabetes field, and I worked with type 2 diabetes all my life, and almost all type 2 diabetes patients, they are overweight. But what we did before these new modern obesity drugs came was that we treated the effects of obesity. We treated the high blood glucose sugar levels in the diabetes. We treated the lipids, and we treated the problems in pain problems in the hypertension, but we didn't treat the ground, I mean the obesity, and now we have the possibilities to do that. And I have so many patients now that have lost weight with modern drugs and modern techniques, and they have reduced hypertension drugs, and they don't eat any pain killers anymore, and lipids are much better, and liver enzymes is much better. So that is the revolution, I think, the paradigm shift, that now for the first time we can also we can treat obesity as a disease, and then all the complications they go away also. That's the revolution, I think.
Yeah, definitely. It's been a huge shift in metabolic health. I mean, Martin, perhaps you can just give like a little brief summary of the the Yazen kind of offer, because I think there's a lot of frustrations there for kind of many patients who really feel they should be getting access to these drugs and aren't at the moment. How do you feel perhaps you can just summarize how the Yazen offer can perhaps help help with that and ensure that people who need them get?
I mean, we have a digital platform and an app, and we offer continuous treatment and continuous care, and where the patients can write to the dietitian or the personal trainer and the psychologist and the doctor, and they will respond within 24 hours, and we can change the medication all the time. So that is important, I think, that, and also the patient can access to educational resources, support groups, and counseling services, and that this will help them to stay informed and motivated. And we have, I mean, I said that I came from diabetes, and in diabetes we often talk about empowerment, that it's a process which individuals gain increased control over decisions and actions that affect their health. And what we want to achieve in our Yazen model is that treating obesity is, in addition to weight control, that the patient will acquire the knowledge and skills to effectively manage their illness and drug treatment on a daily basis. We want to inform them how medicine works, what are the potential side effects, and how they can best be integrated with other aspects of lifestyle changes. And our goal is always to keep the medicine dose so low that the side effects can be minimized, but still achieve optimal medical results. I mean, that is our goal. It's a holistic goal and empowerment for the patients. That is what we're aiming for.
Yeah, that's something we haven't actually really covered so far. I guess the importance of the psychological aspect, and having counselling and access to that support while taking these drugs. Poonam, what's your kind of perspective? From primary care on that. How important is that kind of aspect, the mental health aspect?
Huge, because everything stems from your mind. And I think if you're in the right space of mind, then everything else really can follow on. And, we've mentioned lots of different diseases that can form as a result of obesity, or could be the reason why obesity developed in the first place. Mental health is a huge one. And I think ensuring that someone's mental health is in check, that they are getting the adequate support, that they are met every time as a person that's seen as a whole. I very much believe in, the most important thing is to ask someone at the very beginning, instead of saying, what's the matter with you? It's actually, well, what matters to you? Where are we going in this journey? And I think the beauty of primary care is that you are at the core of it all, and you can piece it together. You can keep touching base with a patient once you've established a diagnosis, but you are also in touch with, whether it's psychology input that's required, whether it's the teeing up of that multidisciplinary team is very, very important. And we have access to that. I appreciate at the moment there is quite a lot of strain and pressure within the healthcare system here in the UK. And there are long wait times, which is why often digital platforms can be very helpful in those circumstances. But that support is there, and everyone works together with the GP, the general practitioner, to help with that. But coming back to mental health, it is probably the biggest issue that's facing us alongside obesity in the UK, for sure. And the more we can tap into that at every step and ensure that the right support is given, the better.
Yeah, definitely. I mean, I do think that perhaps one of the disadvantages of some of the studies so far is that everything is almost kind of focused on the injection. But we almost need kind of trials of weight loss drugs, but plus psychological support to really kind of see, does that actually really help in terms of the long term and preventing people from relapsing, because ultimately a lot of people are going to have to stop taking these injections at some stage. I mean, Jason, Nick, do you have thoughts on that?
I mean, from my perspective, we've long known that the relationship between obesity and depression is bidirectional. If you have one, you're more likely to have the other. And that relationship starts at the age of 7, as the Millennium Cohort study showed us. I think it's very, very important that we focus on the link between physical and mental health. And I think here stress and coping is particularly important, because that might explain some of the issues around particularly the socioeconomic status relationship with obesity as well. It's the ability to have control in your own life, which is quite important. I do think a holistic approach is important. I think the personalisation of this is important. I think it's very useful to understand the person in the moment, in the situation, what leads to the temptation, what can we do to prevent it? What makes that temptation translate into a lapse? How do we break that relationship? These are all important things that when we start breaking these things down on the psychological side, we can use precision tools such as online tools. I think that gives us a great deal of power, and it makes us focus less on the drug, because the drug is the adjunct.
Yes.
Yeah. Definitely. Actually, just following on from that, so just to interrupt you, Nick, sorry, we've had another kind of comment from someone in the chat, Anika, who says, how do you go about coaching a patient to keep on a healthier lifestyle with normal portions, not snacking after the goals are met and they want to get off to treatment? Nick, what?
Well, so my good friend and colleague Carel LaRue, his approach, I don't know whether he really uses this, but his approach to patients is say, if you want to regain, that's the time to stop the treatment. The fact is, this is a chronic disease, and the physiology will try and restore your weight to the heaviest that it was. We see that if bariatric surgery is reversed. You can have kept your weight down for 5-10 years with bariatric surgery. If for some reason it has to be reversed, within weeks, people are regaining weight and will go back to where they were. So we are going to have chronic treatment. That means that we have to make sure that when we start treatment, that our patients understand that this is not like taking antibiotics for 2 weeks that will cure your infection. This is a long-term treatment. Whether people should stay on anti-obesity medications lifelong or not, I think is a harder question. We do know that when they are withdrawn, most people start to regain weight. Whether they regain all the weight loss or not is still not known. And I think a very big gap that we don't know about is if somebody does stop medication and let's say 6 months later restarts it, will it have the same efficacy? And if it does, then we ought to be attuning ourselves, not to saying, oh, well, you tried it, you stopped it, that's it, to saying, okay, let's restart you, just as we would do if somebody is non-adherent with their diabetes medication, their blood pressure medication, or their cholesterol lowering treatment. We don't say, you tried it, you stopped it, no more. So I think we need to not endorse perhaps intermittent treatment, but at least show that if it is necessary or if it can be helpful, that we should be considering it.
Yeah, definitely. Punam, do you think that's important? The need to kind of prepare people beforehand that this isn't just of antibiotics. It's going to be something you're going to be taking long term.
Yeah, I often find by the time somebody has come in, they've tried lots of different things, nothing has worked, and they are essentially, by making that appointment, committing to working with you. But what they need back is that promise that you will do everything to ensure that can work along the way. And so, yeah, absolutely, I agree with everything that's been said there. I think that that constant check-in point is essential, ensuring that people are informed from the very beginning of what is involved in this journey. Compliance is essential, and that would be with any chronic disease discussion when you're placing people on medication, that if they need to work with you. It's a partnership that you're going into, which involves you coming in for those check-ins, the blood tests, the admission where there perhaps have been relapses. I think often patients, either you find that they go the whole way with you, or you hear from them in periods at a time where they go, I'm so sorry, I fell off the wagon, and then I felt worried, and then I didn't come forward, and then I've relapsed, but now I'm back here again. And you just meet them again and say, okay, well, let's start from scratch. How do we build this moving forward? But counselling is essential from the get-go, so that they know exactly, as you would with any procedure in medicine, people need to know the consequences, the complications, but compliance is key.
Yeah, Martin, like, so
it's quite common, I think, that after 1 year, maybe, that when the patients, they have reached the goal, the weight goals, and then they want to try to stop medication and try without. And I respect that. I always say that it's a big risk that you will gain weight, but I mean, I respect that they want to try, and often they come back after 3 or 4 months when they have started gaining weight again. But I understand it from a personal point of view.
Yeah. Well, we've only got like sort of a couple of minutes left, so if there's any last kind of questions, please do just quickly post them in the chat, and we'll try and get a quick reply. But perhaps just to kind of like wrap things up, maybe each of you like sort of could perhaps like go around and just say what you feel are like sort of the next things you kind of expect in the next few years in terms of like sort of weight loss medications and how we kind of manage these pathways.
I think what I hope, not what I expect, what I hope is that obesity will be consistently dealt with as a lifelong relapsing chronic disease, and that we view our interactions with people living with obesity as lifelong management. By management, because there is no cure, by management I mean access to appropriate treatment options and other support through their life course, working with and co-producing the treatment plan with the patient.
Punam, do you agree?
Yeah, absolutely agree. You said it so well there. I would just love open conversations, more of us being able to have easily accessible education from a very young stage. I think that I want society to be a lot more compassionate and empathetic towards those that are living with obesity. And I think just accessibility to all for healthier choices, so that we can start to see trends going in the opposite direction. Now, wouldn't that be just a dream?
Yeah, Nick, what are your thoughts to wrap up?
Well, we've got to do something about prevention, obviously, and that's, I guess, is a political issue. But until politicians accept that they have a responsibility for preventing obesity, I think we're going to have problems. In terms of treatment, we're going to see more drugs, different mechanisms. Increasingly, there will be oral formulations, which will make it a lot easier and almost certainly a lot cheaper. And what we're going to have to learn is what is the right drug for the right patient at the right time.
And Martin, just 30 seconds. What do you feel?
I agree with you all, but I also want to say that, I mean, there will be new drugs, but also that digital care is here to stay, because there are so many benefits with it, and you can have multidisciplinary team wherever you are. If you're somewhere in Scotland or Wales or in Sweden, and you can have access to this all the time. So this is here to stay, I think, and this is a part of the revolution in healthcare, obesity drugs, but also digital care.
Definitely. Well, that's probably all we have time for. So, thank you so much to all our panelists and to everyone for joining us today and sharing your questions and comments. So for more information on all of this, please do head to yazen.co.uk, where you'll be able to listen back to this session in full. So yeah, thank you and goodbye.